Welcome to Solutions to Reduce Disparities, CMS Equity Plan for Medicare 1 Year Later webinar. My name is Christine, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now call over to Caitlin Oppenheimer from NORC. You may begin.
Terrific. Thanks, Christine. Hello, I am Caitlin Oppenheimer from NORC. We provide support to the Centers for Medicare and Medicaid Services Office of Minority Health, and I'm pleased to welcome you to this webinar, Solutions to Reduce Disparities, the CMS Equity Plan for Medicare 1 Year Later. I have a couple of announcements. As Christine indicated, this webinar is being recorded, so we can make it available for folks who couldn't join us today. Your present lines are going to be muted for the duration of the webinar. And we will use the chat feature to submit your questions and answers at any time during this presentation. So you don't need to wait until the end, and just submit the question to the archive operator. I'm going to run through the agenda for our conversation today. As you can see, it is jam-packed. So we will be going through the agenda and holding questions and answers to the very end. Our first presenter is Dr. Kara James, the Office Director of the CMS Office of Minority Health. She will be covering a presentation entitled Equity Matters. Following Dr. James will be Jordan Luke. He is the Director of the Program Alignment and Partner Engagement Group, also in the CMS Office of Minority Health. His presentation will cover building an organizational response to health disparities. Dr. James will proceed. She's the Deputy Chief Medical Officer of the CMS Center for Clinical Standards and Quality. Her presentation will cover From Data to Action, Mapping Medicare Disparities Tool. Following her Ling will be Dr. Alexander B. Yu. He's the Acting Director of the Division of Population Health, Incentives, and Infrastructure, and the Prevention Population Health Group at CMS Center for Medicare and Medicaid Innovation. His presentation is covering accountable health communities. Following the presentation, we'll hear from Jessica Briefer-French. She's an Assistant Vice President for Research at the National Committee for Quality Assurance. She's been covering Implementing Culturally and Linguistically Appropriate Services Standards, a Practical Guide. Next, we'll hear from Lin Hao. He's the Director of the Division of Practitioner Services, the Hospital and Ambulatory Policy Group at the CMS Center for Medicare. He's going to be covering Improving Care for Individuals with Disabilities, Proposed Changes to Physician Payment. Our last formal presentation will be by Dr. Madeline Shea, the Deputy Director of the CMS Office of Minority Health. She will take us to the end of the presentation period with a talk covering Looking Forward, and we'll do our questions and answers. Now, it's my privilege to introduce Dr. Kara James. As I mentioned, she's the Director of the Office of Minority Health at the Centers for Medicare and Medicaid Services. CMS OMH serves as the principal advisor and coordinator to the agency on the unique needs of minority and disadvantaged populations. Under Dr. James's leadership, CMS OMH has made significant strides towards achieving its mission of improved minority health, reduced care disparities, and the attainment of health equity. Her work has led to the development of two of the office's flagship initiatives, From Courage to Care and CMS's Equity Plan for Improving Quality in Medicare, which we are here to talk about today. Kara?
Thank you so much, Caitlin, and good afternoon to all of you, and good morning to you who are joining us on the West Coast. Next slide. I'm excited today to talk to you guys about our equity plan and the efforts that we've had 1 year later. Next slide, please. To give you a little bit of an overview of who we are, for those of you who may not be as familiar with the CMS Office of Minority Health, wanted to take a moment to let you know who we are and what we are up to. As a relatively new office within the Centers for Medicare and Medicaid Services, our mission, as you can see, is to ensure that the voices and the needs of the populations we represent are represented throughout the agency as we're developing, implementing, and evaluating our programs and policies. And we're working towards a vision in which all populations have achieved their highest level of health, and disparities in healthcare access and quality have been eliminated. Next. We go through our work on our path to equity and it really embodies our three-part framework for achieving health equity. The first is the U of increasing understanding and awareness, if you could go back one, please, of health disparities and their causes. Our S is in developing and disseminating solutions to address the disparities that we see. And the A is implementing sustainable action. This is work throughout our office and as we see our path to achieving health equity. Next, please. A year ago, when we started developing the equity plan for improving quality in Medicare, this was the state of what we saw in terms of health disparities. We saw over time disparities in healthcare quality and access are largely remaining the same. And while quality is improving for everyone, we've not seen the same benefits in terms of the reductions of disparities. So we thought it was important to really focus on what we can do to address those gaps, to reduce disparities, to work towards that achieving health equity. Next slide, please. This is the development of our equity plan for improving quality in Medicare, which has 6 priorities. And we're excited today to take you through some of the work that we've been doing within these priorities. The first priority is to expand the collection, reporting, and analysis of standardized data. The second priority is evaluating disparities impacts and integrating equity solutions across CMS programs. Third is to develop and disseminate promising approaches to reduce health disparities. Fourth, increase the ability of the healthcare workforce to meet the needs of vulnerable populations. Fifth is to improve communication and language access for individuals with limited English proficiency, as well as persons with disabilities. And our next priority is to increase physical accessibility of healthcare facilities. These priorities came from listening sessions that we did around the country from stakeholders who are experts not only in our priority populations within our office, but also stakeholders who work across CMS in our different programs. And so we're excited, as I mentioned, to talk about some of the efforts that we've had underway in the course of the year and look forward to what we have coming up next. With that, I'll turn it over to Jordan.
Thank you, Dr. James. As Karen mentioned, my name is Jordan Luke. I'm the Group Director of Program Alignment and Partner Engagement. And I'm going to give you some examples today of what our work looks like. As Dr. James mentioned, our path is framed in 3 ways. We focus on increasing understanding and awareness of disparities, developing and disseminating solutions, and implementing sustainable actions. And 4 examples that we're going to highlight throughout this presentation today of how we're advancing equity within CMS. One that you'll see is around data analysis. Another one is with the element of policy and programs. Third, the development of resources. And finally, technical assistance for those that, understand that disparities exist but aren't sure where to start. Next slide, please. So things that we've heard as we've had listening sessions with various stakeholders that are trying to identify where to start is that there are a lot of different challenges as it relates to disparities, and there are many paths to pursuing equity. And so the conundrum that many organizations face is they don't know where to start. Do you with embedding equity in the culture? Do you improve the analysis of the data? Are there interventions that you implement? What are the resources? And it is all of the above, but I think it's helpful to give some real-world examples of what that looks like. Next, please. So one that we developed earlier this year is called Building an Organizational Response to Health Disparities, which is a series that will consist of various resources over the coming years to support the actions of organizations that are ready to tackle health disparities. And this resource is split up into 5 different sections. It focuses on data collection, data analysis, quality improvement, targeted interventions, and a culture of equity. And if you're working on the first 4, then by definition you're already embedding equity in the culture of the organization. Slide, please. Aside from other resources that we've also developed, for example, we released a Mapping Medicare Disparities resource earlier this year, which Dr. will talk about in a bit, which has fee-for-service Medicare data on a mapping tool at the county, state, and national level. And for Medicare Advantage plans, we also released HEDIS and CAHPS data stratified by race and ethnicity. And then we're also releasing resources to help organizations understand how they can improve their data collection process with race, ethnicity, sexual orientation, gender identity, language, disability. And then, recently we released the Coverage to Care, which is a resource for beneficiaries that recently gained coverage, but coverage doesn't necessarily mean care, and this is a blueprint of how they can access better care. Next slide, please. So I want to mention before we jump into the presentation, our office recently launched Health Equity Technical Assistance. Because yes, there are resources out there to support your actions, but you may not know where to start, and so offer a series of consults to work with your champions to identify how your organization can tackle disparities and set smart aims. To work with you if your organization needs that support. But I like this slide too because maybe your organization is wanting to develop their own technical assistance within their organization, because you may have champions and subject matter experts on health equity that can support the operations of your organization to really build out the capacity and readiness to start to tackle health disparities. And so this is a great framework to use in thinking about how you develop that. So that's just a snapshot of our work over the last year. But now we're going to jump into some real-world examples of how we're embedding equity across CMS. And it's a pleasure to present Dr. Sherry Lang. She's the Deputy Chief Medical Officer of CMS Center for Clinical Standards and Quality, and she's covering from data to action, the Mapping Medicare Disparities tool.
Thank you so much, Jordan, and good afternoon to all. And if we could actually go to the next slide. What you should all be viewing here is a visual display of our national fee-for-service data. A visual depiction of the disparities that currently exist. We talk about delivering high-quality, high-value health care and achieving better outcomes. Our mission, as articulated by Dr. James, is that we do so equitably, and that's what the plan is about. And the tool, this Mapping Medicare Disparities tool, helps you get started in displaying where there is actionable opportunity to improve. So if you actually look at the bottom of the slide, it gives you the web link that will take you to this tool, and you'll soon discover that you're able to map disparities in prevalence by race, ethnicity, sex, group, but also do so and dive in not only at a national level, but dive deeper to the state and county level, and also display what you're interested in by dual eligible status, that is Medicare and Medicaid. If we go to the next slide, please. Data permits a graphic display of the fee-for-service data for important health services that are delivered and that CMS tracks. It includes admission rates, avoidable hospital events, and also mortality as well as prevalence. And as suggested by the slide, you can display and have a high-level number of state and national averages and are able to compare prevalence of 18 chronic conditions across every state across our great nation. But also you can also display the prevalence of chronic conditions across different counties within a state. So giving greater granularity to the prevalence and resources used to address these high-cost, high-prevalence conditions. So geographic variability is displayable. And likewise, you can actually dive deeper to obtain a better understanding of what the nature of some of the disparities might be. Next slide, please. So just as a high-level and brief example, as many of you may know, CMS has been working on contributing to the Vice President's Cancer Moonshot Initiative. And as part of that, taken interest in the prevalence of cancers across our country. And suggested in this slide, one example is to look at the racial disparities within a specific county. And here we can demonstrate that there is disparity, that the prevalence of cancers is 20% for African Americans, while only 4% within that same county. And this actually raises many questions and points out opportunities for improvement that could not only mitigate the disparities, but improve quality for all. On the slide, as a second example, we've displayed for you the prevalence of diabetes, and many of you already know high prevalence exists within our southern states, but what of our territories? And here, if we actually look at the data and display the data, we can see that although the prevalence in Alabama is 24%, the prevalence of diabetes is actually 47% in Puerto Rico. So again, raising awareness and actionable opportunities for improvement through use and display of the data. Next slide, please. Now, I briefly mentioned the prevalence of diabetes that is also disparate across our country, but what of the short-term complications of this increasingly prevalent condition? And what is displayed here is within the state of West Virginia, we have a display of 2012 to 2014 and can see notable trends over time. Although these are two cross-sectional snapshots, point out the disparities that exist over time as well as within this single geographic location. And the next slide, please. And this information then is also displayable in tabular form. That is, again, short-term diabetes complications for African Americans versus whites, and a computation of the ratio of the short-term complications, but importantly, over time, enabling us to depict, measure, and therefore develop tactics and strategies to improve on and mitigate the disparities that are measurable across our country and within geographic regions. So one measure, we measure to improve, and this is a powerful tool that I'm delighted and honored to introduce you all to allow you to get acquainted with and also utilize for your purposes of improvement. And with that, I would like to turn the mic over to Dr. Alex BU. He is Acting Director, Division of Population Health Incentives and Infrastructure in the Prevention and Population Health Group in CMMI to talk about accountable health communities. Alex.
Thank you, Dr. Ling, and thank you, Dr. James, and everybody on the line today. Really appreciate this opportunity to share with you a little bit about our model, the Accountable Health Communities model, being operated out of the Center for Medicare and Medicaid Innovation, as I said earlier. And this was an office, a center established under the Affordable Care Act to develop and test new models of care delivery aimed at reducing the costs of care for our beneficiaries and improving the overall quality of their care, and we would underline in the Prevention and Population Health Group improving their health. And so while I think that the work I'm about to share with you covers at least the first 4 priorities that Dr. James shared, I think we're most solidly in priority 3 and 4, really developing a new approach to reducing disparities and doing that through increasing the healthcare workforce's ability to meet the needs of vulnerable populations. Next slide, please. So the underlying idea to the Accountable Health Communities model was that, as is widely dispersed now, only about 20% of the work, or the work that we do rather, only impacts about 20% of the overall health of beneficiaries. That is, what we do within a healthcare system in our clinics and our hospitals that we support has a significant but relatively circumscribed impact on the health of beneficiaries. And so the Accountable Health Communities model tries to tap into some of that other large proportion of what impacts the health of our beneficiaries to make a significant change. This is supported by evidence that actually intervening on individuals and beneficiaries' social and economic determinants of health can actually have a significant improvement in their overall health outcome, reduce their utilization, and thus have an improvement in health costs as well. And so our model really seeks to define a way for health systems to be able to reach outside their walls, identify and connect their most vulnerable beneficiaries and members with the resources in their communities to help address those health disparities. Next slide. So the model is a 5-year model that will test whether systematically identifying health-related social needs amongst our community-dwelling Medicare, Medicaid, and CHIP beneficiaries, and then connecting them to community services to meet those needs will impact their health quality, utilization, and costs. Next slide. To do this, we focus on 5 specific core areas of health-related social needs. These are housing instability, utility needs, food insecurity, interpersonal violence, and transportation needs. And these are areas that have very strong evidence of impact on individuals' health, as well as strong evidence that intervening and supporting these needs can actually improve the health of individuals. The model will also allow individual participants in the model, bridge organizations, as I'll describe in the next coming slide, to evaluate other supplemental needs that we think are also important that may not meet that core need distinction. And these include family and social supports, education, employment and income, and health behaviors. Next slide. You see our graphical description of the model, and essentially the applicant to the model is the bridge organization at the center, at the hub of this wheel. And around the top, we have the clinical delivery sites most familiar to us in the Center for Medicare and Medicaid Services, including hospitals, primary care sites, and behavioral health sites. And they essentially will be the sites for screening all of the Medicaid and Medicare beneficiaries that come through their doors for health-related social needs. And then through the bridge organization, they'll connect them to these community service providers you see on the bottom, meeting those core health-related social needs. Next slide. The model itself takes 3 different approaches to connecting beneficiaries to services. In track 1, we increase beneficiary awareness of available community services through information dissemination and referral, and that's done through a community service referral sheet. In track 2, we go a step further than just giving a referral to beneficiaries and connect them to those to navigators operating by their bridge organizations to really help beneficiaries make those connections with community service providers and to help follow up and troubleshoot any difficulties that individual beneficiaries may have in seeking those services in their community. Finally, in the alignment track, we go a step further and engage this community of bridge organization, clinical service providers, and community service providers to engage in gap analysis and quality improvement activities to really identify what health-related social needs are not being met or being inadequately met and develop plans to improve these. Next slide. And so key to the underlying principle of this model is that it's rooted in making sure that our health resources are really totally mobilized to address issues of equity. And so as a part of the application for the model, applicants are asked to perform what's called develop what's called a health resource equity statement. This is a disparities action statement that's supposed to help the bridge organization in identifying the target minority and underserved populations that they plan to address through the model, and then assess how the model will relate with these subpopulations that they've identified, especially noting how they'll ensure that they'll have inclusion and evaluate that inclusion of subpopulations both in the community and through the model. And then finally, longitudinally track the process and outcome of the engagement of these subpopulations throughout the 5-year Accountable Health Communities performance period. We're launching the model at the end of, or rather in spring of 2017 with our first Track 2 and 3 applicants joining. And then in the summer of 2017, we hope to have our Track 1 awardees join as well. And we look forward to, in the years to come, sharing more information about the impact that this exciting model is having. Thank you. And with that, I will turn it over to Jessica French.
Thank you. We're all here because we care about health equity. At the start of this webinar, Dr. James made the case for health equity, and I think we can all agree something needs to be done. But what does it take to achieve health equity, and what kind of change will be needed? The previous presenters have described the many ways CMS OMH is helping healthcare organizations to improve. I'm pleased that NCQA has been able to participate in that important work, and I want to introduce you to a new resource that will be coming soon to address health equity. Culturally and linguistically appropriate service standards, a practical guide. It's a mouthful. This toolkit supports priority 3 of the equity plan, develop and disseminate promising approaches to reduce healthcare disparities. This is part of the strategy that Jordan Luke described, building an organization response to health disparities. Next, please. The national class standards were released originally in 2000 and updated in 2013 to broaden their focus beyond racial, ethnic, and linguistic minorities to include other underserved populations. One approach to improving health equity is to implement the national class standards, and this new guide is a resource to help. Next slide. Over the years, NCQA has worked with CMS OMH to identify opportunities for measurement and improvement of class for racial and ethnic minorities, people with low health literacy, people with disabilities, and sexual and gender minorities. A number of recommendations around data collection, measure stratification, enhancing the use of patient-reported measures of culturally and linguistically appropriate services, and improving organizational capacity to address class and to provide culturally competent care. Next slide, please. A practical guide to implementing the national class standards is one part of a broad strategy to support healthcare organizations in moving the equity agenda. And a resource that you might recognize, the logo and the look focuses on data collection. This contains dozens of resources on class, from information to training materials to practical plug-and-play tools. The resources have been vetted by a panel of experts in class and health equity, and they're organized for easy reference. Next slide. They're searchable by class standard, by population addressed, by type of resource, by user, and by healthcare setting. In addition, there's a topical index, so you can browse through the material or identify specific resources to address your particular problem, population, or setting. Next slide. Slide, and you don't need to actually read it. I just wanted to offer a quick taste of what's inside the toolkit and what it looks like. This is an example of how a chapter is organized. This is the chapter on governance, leadership, and workforce. The third resource listed next to the snowflake icon, which denotes a practical tool, is shown on the next slide. Please advance. This resource addresses health literacy. The slide shows clips from multiple chapters within the guidebook to building health literate organizations. If you need background information for presentations or training or to make a case for change, if you need easy-to-use plug-and-play materials or off-the-shelf staff training programs, or just examples of successful strategies that other organizations have implemented, watch the CMS OMH website. This toolkit will be posted very soon. Next, I turn the mic over to Ryan Howe to discuss improving care for individuals with disabilities.
Everybody, thank you, Jessica, and everyone. I appreciate the opportunity to present our issues here. I work in the Center for Medicare in the payment policy area that addresses Medicare fee-for-service payment under the physician fee schedule. Sort of a payment methodology that underpins much of the healthcare system, and over several years we've identified and recognized how we might improve the accuracy of payment to the physician community and other practitioners to help improve the care for the different patient populations. One of the sort of fundamental mechanisms of payment under the physician fee schedule and fee-for-service in general has to do with the way services are described and billed. Under the physician fee schedule, there are thousands and thousands of codes that describe diagnostic tests and procedures, and relatively few codes that describe primary care visits and other kinds of cognitive services. And what that means in a big picture perspective is that there's a lot of payment differences and a lot of increased payment for particular kinds of services, but for other services like primary care services and care management services, there's sort of a blanket one-size-fits-all payment. And for different patient populations with different medical needs, that one-size-fits-all payment has proven to be problematic. So over several years, CMS has endeavored to improve the accuracy of payment under the fee schedule to recognize the differential costs for furnishing services to patients with different medical needs. And that's happened over several years. Beginning in 2013, Medicare began making separate payment for what are called transitional care management services. These are the care coordination activities that physicians and other practitioners engage in the month that patients are discharged from facilities, so from a hospital or skilled nursing facility. Similarly, and importantly, in 2015, Medicare began making payment for what's called chronic care management services. That's a separate payment to recognize a month's worth of care management services to physicians who provide non-face-to-face care to patients with multiple chronic conditions. This is, of course, opposed to the pre-existing circumstance where the physician would only be paid for in-person visits, for example. But beginning in 2015, physicians who manage the care of patients through phone calls, medication management, et cetera, can be paid under fee-for-service Medicare for those services. For 2017, we made several proposals in this arena, and we finalized most of them. The few that I wanted to mention here, we proposed and finalized policy to increase the accuracy, we believe, of the payment for chronic care management by making payment for what we call complex chronic care management. These are patients that have additional needs, and so there's increased payment there, as well as proposing and finalizing several changes in policy to reduce some of the administrative burden for billing those services. Next slide. We also proposed and finalized payment for what we call behavioral health integration services broadly. These are the kind of services where primary care practices are coordinating with psychiatric experts, psychiatrists, and managing the care of patients through consultative work. And for patients with behavioral health conditions, which is a population in the country, we believe that such integration is important for providing the best care, and that the payment codes will allow care to make appropriate payment based on resource costs of furnishing those services. We proposed to use 4 separate codes And if you're interested, I definitely refer you to the physician fee schedule rule to take a look at the different conditions of payment and the different descriptions of those codes. We similarly, next slide, propose to make payment for specific payment for assessment and care planning for patients with cognitive impairments. These again would be until 2017 would be billed using sort of standard visit codes, and now more specific payment under Medicare can be made for those services. We also proposed in the 2017 proposed rule to make payment using a code that described the resource use for patients with particular kinds of mobility impairments and the particular kinds of equipment costs associated with furnishing those services. We received a lot of comments on that particular proposal that gave us a lot of reason to think about that particular proposal, and we continue to do so. And we did not finalize payment for those services for 2017. But we consider much of this work to be ongoing and continue to seek information from the community about we can improve payment for the physician and practitioner community in furnishing services to patients with particular needs. And with that, I'll turn it over to Dr. Maddie Shea.
Thank you. Thank you, Ryan. And I want to thank all of our partners who have been on this call today with us, describing how we are partnering to embed equity across Medicare, Medicaid, and all the work that CMS is doing. What you just heard, I think, was really significant progress from Dr. Howell. So thank you for that. I think, and I'll reach out and let you know that if there's any questions as these new possibilities are put in place about that and whether that applies to you, please let us know, because I know that there's a lot of confusion sometimes about this, and we are here to make sure that all the work that's gone into making some of this possible really benefits those that we hope to benefit. So looking forward, you've heard about some of the really great progress over our first year with the CMS Equity Plan for Medicare. And this is just a beginning for us. We've learned a lot this past year, have great plans to continue the work that's been started. So if we're thinking back to that USA framework, we're still very, very committed to the idea that it's hard to work on disparities unless you understand them. So one of the things that we'll be doing, in fact, this week, is we're updating the certified reports for Medicare Part C and D plans, so that those plans can understand disparities by race and ethnicity. So to give you a sense of what does that mean, the measures include things like body mass index disparities among plan members, breast cancer screenings, colorectal screenings. There are 4 different measures on diabetes management for people who already have diabetes. These are things where plans can see how they're doing for different populations. In addition, there's CAHPS measures there. So those are measures where you can hear from the plan members themselves about their care coordination, about their flu vaccine rates, customer service, so that we can all continue to work together to understand disparities and then to do something about them. So that hit a little bit of what you'll be seeing in on this upcoming year for Priority 1. For Priority 2, we're putting in place the technical assistance process so that anyone who wants to act on even start to understand their disparities, quite frankly, or then to understand solutions or put actions in place, will have the help they need to get there. We're here, and if you were to go to our website or to our plan for next year, which is website, you can see how to access that technical assistance, and we're standing by ready to do that. With Priority 3, I don't think we've mentioned, but we had started with a readmissions guide, a guide for healthcare stakeholders on how to reduce avoidable readmissions to hospitals. And so that resource is going to be updated based on the experiences of people like those on the phone today. We also are expanding our library of organizational response resources to include resources focused on diabetes, quality, and care and engagement. Just a few. I do invite you to go to our annual update. Our accomplishments report for year 1 includes plans for next year. So in priority 4, we are going to be expanding resources for you that are available in the Medicare Learning Network, as well as identifying promising practices going on all across the nation right at this moment, and helping you to see what different solutions look like in different communities right now in the U.S. For priority 4, the Mapping Medicare Disparities tool is going to be enhanced to include a really neat resource on what are the languages spoken in the different communities where you are working, and to be able to see that more easily, as well as the prevalence of disabilities. So that's something that you can look forward to. Then for priority 6, as you heard with our payment update in the physician fee schedule, we're going to continue to work on figuring out what the right approach is there. We'll also be sharing how-tos that have used by communities in the country that, I won't name them, but there are some states and communities that have really made progress in increasing the physical accessibility of healthcare facilities. So we'll be sharing that so that you'll have that resource. So that's just to kind of hope get you excited to go to our website and check out what's going on. But at this point, I think we're ready to open up the floor for questions that you can put into the chat box that we can then answer. I did want to start with a question for Jordan Luke. Where can we learn about best practices for collecting standardized demographic data?
That's a great question, Maddie. And we recently updated our website. It looks beautiful, and it's much easier to find resources on there. I still find the easiest way to look it up, aside from looking it up on CMS, Google CMS, OMH, and on the main page you'll see a header for research and data. One of those is focused on statistics and data. In that area you can locate the stratified reporting, and you can also locate the compendium resource on how to collect race and ethnicity, which is basically a best practices guide for organizations that know that this needs to be done but don't know exactly where to start. And Kate, we'll turn it over to you if we have more questions.
Well, for Caitlin, I'll give you that specific URL for our website. It is go.cms.gov/CMS-MH.
Caitlin? Okay, we have another question, Dr. James, which I'll share with you. It's, how can we receive health equity technical assistance?
Hi, Jordan. This is Kate. We're back in the line. It's the old mute button next to the hang up button, which caused us technical difficulties. Sorry about that.
Okay, just shared the second question with Dr. James, and then we'll hand it back over to you.
So for those of you who are interested in getting technical assistance and helping to develop your own action statement to address health disparities, again, you can find that information on our website, which is go.cms cms.gov/CMS-OMH, and you'll find the technical assistance resources there and a link to the Disparities Action Statement.
Thanks, Dr. James. And Ms. Caitlin also wanted to answer a question that's come up in the from participants, that we will make the slides available in the coming days. So once we have them available, we will send them to the people who have requested them, as well as having the files available on the website. So here is a question, Jordan. Do you have disparity information for managed care, both Medicare and Medicaid, and resources may be available for populations served by these programs?
Yeah, I talked about the Part C and Part D HEDIS and CAHPS report that's stratified by race and ethnicity. I believe this was mentioned, but I'll just highlight again. That data is not only at the national level, but what's really useful is that it is at the H contract or S contract level. So let's say your organization doesn't have the ability yet to stratify your own data. This serves as a starting point to start to look at your own data and see where disparities exist, and to even compare how you're doing with the national averages. So Dr. Shea mentioned a few of the measures that are on there, but for those that are in the HEDIS and CAHPS world, you're very familiar with this. But I think what is very useful is that this is at the H contract level, and this is on our website, which the update was just released today, actually. So.
Great. We have a follow-up question related to technical assistance, and just wondering, the requester was wondering if you could provide more information about what the health equity technical assistance might entail.
The Health Equity Technical Assistance is a series of consults, and it's tailored to whatever your needs are. But what we offer are 3 consults to really understand what your needs are and put the right resources in your hand. So the right place to start, if you want to do an email to healthequityta@cmshhs.gov, I'll repeat that one more time. That's healthequityta@cms.gov, and we'll respond with more information about this technical assistance that we do offer. But in essence, it's a series of 3 consults that we offer.
Thanks, Jordan. This is an issue, Maddie, this is Caitlin, that you have done some work on. Could you say a little bit more about the work that is planned for the priority area 6 related to disability? So one of the respondents queried whether or not there's been anything that's been done looking at additional enforcement of laws and making more information available about the laws surrounding physical accessibility of facilities.
So we have done a really thorough scan of the physical accessibility environment, both the enforcement environment, what are laws, regulations, what are consumer rights, as well as the quality aspects of this. How is the quality of health care measured in terms of disability? And some states have produced their own enforcement environments. A lot does revolve around the ADA, the Americans with Disabilities Act, and aspects of that. So we are going to be sharing before the end of this year an issue brief that will lay out what this environment is at the national level, as well as looking more closely in some states that have made greater progress, what the levers are that people can use to ensure that there's physical access to health care in their local communities, and resources that are available. So that's coming up. And we'll be happy to push this out, figure out how to do that to everyone who signed up for this webinar.
Great. The questions are coming in rapidly. It's hard to keep pace with the questions. One respondent asked, or one participant asked, on the website, do you provide guidance on calculating disparities on the website? And if not, where might somebody find information and resources about how they should go about calculating best practices?
On our website, we have, in terms of the methodology that we've used for the stratified reporting, some of the disparities that we've looked at. You can also find the National Healthcare Disparities Report is on the Agency for Healthcare Research and Quality's website. So if you go to ahrq.gov, their National Disparities Report, National Quality Report, calculates disparities, and they talk about the methodology that they use to do so. So those are a couple of the resources I would point to you. There is obviously sort of question about how you measure disparities. People sometimes measure them typically against, for ethnic disparities, non-Hispanic whites. Sometimes groups have measured disparities against the group that is performing the best, which is, as you'll see with the National Healthcare Disparities Report and even with our stratified reporting, not always non-Hispanic whites. But there is some discussion that sometimes happens about where you calculate that. But those are two resources I would point you to learn about how we've calculated disparities.
It may be that somebody, we have to take a look for this, but a respondent asked if we could give the exact website for where to find the stratified HEDIS and CAP data. They'd like to be able to take a look at that, and they're having trouble finding it on the website.
So to go.cms.gov/CMS-OMH. Under data resources, I think it's data and resources, roughly speaking, it's bottom left. We'll find on the site there data and statistics, statistics and data, and if you click there, you'll see the data that we had posted.
Great. Here's a question that I think this is perhaps in many folks' minds. How should a health plan reconcile the need to treat Medicare members in a consistent and equivalent manner with the need to have a targeted strategy to support members that are at high risk for health disparities?
Well, I mean, I think the framework that we provided is a great place to start. You know, the CMS Equity Plan for improving quality Medicare is a good way to think about how you prioritize your work, because that's the challenge, right? They're limited resources. The budgets are very large, and you know, prioritizing the work is a challenge. So I think, you know, when thinking about how you frame your work, the equity plan serves as a blueprint for organizations that don't know where to start. And when thinking about how that frame looks like, the path to equity is useful as well. You know, focusing on increasing understanding, increasing solutions and action as well. So that I would point organizations to the equity plan for Medicare as a place to start in thinking about how you prioritize your work and provide equitable care to all your beneficiaries.
Thank you, Jordan. We had a question related to either current or sort of upcoming plans to help address strategies for increasing the number of healthcare members in the workforce. So what type of formal disparities training might you recommend to help improve understanding for the workforce, or thinking about the work that the office is doing to strengthen the healthcare workforce to meet the needs of a diverse population?
We're in the process of working with the Medicare Learning Network. There are some excellent resources on the CMS webpage that provide training to the workforce, and so we're identifying the right resources to embed the different tools that we're developing in our office. Some of the tools you heard about today, others are on our webpage. So that would be a great place to start when thinking about how you train your workforce. That's the Medicare Learning Network, which is very easy to locate on the CMS page.
And the national class standards that Jeff French spoke to are also a really good resource, I think, for you to take a look at.
Great.
One question that we got also was an expression of gratitude for suggestions on collecting disability stratified data, and a question about when CMS may begin collecting data by disability status in addition to race and ethnicity, and if you could speak to that issue.
CMS already does collect on quite a number of some of our surveys. We have on the CAP surveys, we do capture information about disability as well as on some of the applications. I think what we were mentioning in terms of the new Mapping Medicare Disparities tool is adding some more of that information to the tool, coming from sources like the American Community Survey that has the standards that were implemented through Section 4302 of the Affordable Care Act. But we do capture, and we have in our duals office, a lot of information on disability.
Terrific, Dr. James. So that's all the time we have today to answer questions and for this session. I want to reiterate that we'll make the slides and available, and we will work to provide a list of the web resources that have been mentioned today, even if they weren't part of the slides, so that participants can go directly to the source. We're grateful for everyone's time today, and we hope that you have heard and feel a little bit more connected to the CMS Office of Minority Health and the important work that they're doing.
Thank you, and thank you, ladies and gentlemen. This concludes today's webinar. Thank you for participating. You may now disconnect.